Greetings and welcome to EHA Unplugged, the official podcast channel of the European Hematology Association, EHA.
Hello, I am Isabel Olivera, a medical writer for EHA, the European Hematology Association. Welcome to this podcast on the GoCART Coalition. Today, I have the pleasure to be joined by Professor Christian Chabannon. Welcome. Could you please start by introducing yourself to our audience?
Yes, Isabel, thank you for having me here. I am Christian Chabannon. I am a French hematologist physician working in Marseille. I work both at Aix Marseille Université and at the Institut Paoli-Calmette Comprehensive Cancer Center that hosts a large hematology department, a large transplant program, and more recently, we have onboarded all the CAR T-cells activities as well with several other programs that plan to deliver gene therapies to various categories of patients.
Thank you for being with us today. So to start things off, can you please explain what is the GoCART Coalition?
So the GoCART Coalition was created in 2020 during the second European EBMT-EHA CAR T-cells meeting that took place in Sitges in Spain. And several individuals, including myself, working already either with EBMT or with EHA, thought that we needed a sort of collaborative space where to bring the different interested parties around the table and foster exchanges. I think advanced therapies in general, CAR T-cells in particular, raise very specific questions, both in terms of development, preclinical and early clinical development, but also in terms of equitable access, safe administration, that have never been encountered previously with conventional drugs and medicinal products. And this can be solved only if all interested parties work together to, again, solve this very complex and multifactorial issues. So that was the intention of GoCART Coalition, to create this open, transparent community and have not only academic representatives, but also representatives from the industry, from healthcare organizations, both at the national and European levels, and most importantly, patients, representatives and advocates.
So it was founded by EHA and EBMT together.
Right. And this was also a very symbolic achievement that two European professional associations came to jointly support a raising initiative. And one of the very important strategic aspects of the GoCART Coalition was to avoid redundancies. So that was one of the motivations behind the creation of GoCART Coalition, so that we would take advantage of the expertise of those different individuals that primarily work with EBMT or primarily work with EHA and bring them together.
So what are the goals of this coalition?
The goal is first of all to help European teams to close the gap with teams in North America and in Asia in terms of development. Unfortunately, it is fair to say that Europe pretty much missed the early phase of development for immune effector cells-based therapy. So GoCART Coalition, one of the objectives is to help European teams to get together. The second aspect is to foster access to these therapies. Through that, we hope that we will increase the different levels of access across European countries. And this is one of the main goals. And finally, trying to better understand what patients want and need. And doctors are a bit, I would say, rudimentary in their thinking. We very often measure our success in how do we improve survival. But if you listen to patients, I think patients will tell you that, okay, this is not only a matter of quantity, this is also a matter of quality. So this is also something that the GoCART is trying to address.
So in your website, you list 5 work packages. There is data harmonization, there is standards of care, education and training, policy and advocacy, and scientific excellence. Can we have a quick overview what the activities of GoCART have been on each of these fields or directions? Can we start first by standards of care?
Well, standards of care, again, trying to reduce variability across centers in several aspects of medical practice. Areas that have been addressed are one, collection of the starting materials that allows to initiate the manufacturing of the medicinal product. So there is a group of experts trying to define what are the best practices in the field in terms of, planning the collection, fine-tuning the parameters during collection, maybe predict what is the quality of the collected cell product and how it will in turn affect the clinical efficacy of the final product. So this group has already published one paper and is working on a second one. How do pharmacists receive, store, handle, and administer the product to the patients has been the concern for another group of experts. And this group also published recommendations and guidelines in a recent manuscript. And this is only for the supply chain, but of course, mitigating the risks of side effects when treating patients is another area where we can contribute to produce and improve guidelines.
So you are trying in general to harmonize practices across countries, across centers. Also harmonize center qualification? Is that also?
Yeah, this is correct. The center qualification process is a very time-consuming process that is currently being imposed by all the pharma companies that manufacture CAR T-cells. They pretty much look at your quality management system, and they provide some specific education to, again, mitigate risks, specific risks associated with the administration of CAR T-cells. In fact, more than 6 years after the first market approvals in Europe, all centers and all specialists have come to the conclusion that these pharma-specific qualification processes are largely redundant. So the idea is that to alleviate the workload imposed on centers, there could be a core training and a core evaluation that could actually be subcontracted to a third, an independent party. And that could be JC, which is the EBMT accreditation system in place for more than 25 years now, and that also overviews many of the aspects necessary for CAR T-cells that are already in place due to the pre-existence of hematopoietic cell transplant programs. So JC may cover the core aspects of the qualification process for centers, and then pharma would have to deal only with the specific aspects of their products and their indications.
So this could be part of the needs in education and training too. GoCART is also...
So center qualification mostly reflects a global organization, including the quality management system. And on top of that, we believe that different categories of healthcare professionals do need to have some specific training for the management of patients treated with CAR T-cells. And so this is what we recently designed as the Passport Initiative, which is sort of a driving license with limited validity in time to actually testify that one given individual has acquired the minimal essential knowledge that is needed to, again, ensure patient safety and treatment efficacy. And we are working to build this individual passport, taking advantage of existing educational initiatives and tools. One of them is the CAR T handbook. The CAR T handbook was, the first edition was published a couple of years ago. And again, that was an initiative supported both by EHA and EBMT. So we are revising and expanding the content of the CAR T handbook. We have designed it in a purely digitalized format so that revisions can happen more often as needed with the advance in knowledge, and the content will be used to design an exam that will allow people to get the passport. Another important aspect in the passport is that it will go beyond training of people at treating centers, because we also realize that a critical aspect in access is that the hospitals that cannot directly deliver CAR T-cells still need some professionals to have knowledge and expertise in CAR T-cell treatments.
To identify the right patients at the right time.
Absolutely.
So in policy and advocacy, there is a regulatory framework called hospital exception, a framework from the European Union that allows academic centers and hospitals to develop ATMPs, such as CAR Ts. So we heard in this meeting from Julio Delgado that this hospital exemption is being revised and a bit at risk. What is the CAR T Coalition doing about this?
Well, the GoCART Coalition is trying to produce some recommendations to policymakers at the European level to stress and emphasize how important it is that the hospital exemption is maintained in the next version of the pharma regulation and the ATMP regulation. So maybe for people who are not aficionados of the regulation, I need to explain a little bit. When advanced therapies are made or manufactured from cells, their manufacturing process borrows both from the practice in cell transplants and from more or less sophisticated biotechnological processes. But these biotechnological processes result in significant changes in the functions of the collected cells, and this is where the frontier is between cell transplant and medicinal products. But historically, in Europe and across the world, medicinal products are manufactured by the industry and intended to be placed on the market. So once the original version of the regulation, the European regulation on advanced therapy medicinal products, was released in 2007, that meant that some of the therapeutic products that were previously produced and distributed by tissue establishments were then classified as medicinal products. And then the consequence was that they had to be manufactured by pharma companies. And for some of those products, pharma companies have no interest because they consider there is such a tiny market. So the first version of the regulation contained a provision that was called the hospital exemption, allowing some tissue establishment, academic infrastructures, small private infrastructures to manufacture some batches of advanced therapies such as CAR T-cells to cover these needs for orphan situations. So there are huge differences in the way that the different countries implement the hospital exemption. You mentioned Spain, where there has been a remarkable project and work carried out to make CAR T-cells available to a fraction of Spanish patients, taking advantage of the hospital exemption. I am French and living in a country where the policy is totally opposite. Our competent authority is very reluctant to allowing academic infrastructures to produce some small batches. But obviously we have a problem because the implementation of the hospital exemption is quite heterogeneous across countries. And this is one of the reasons why it's being discussed currently at the European level, because the pharma regulation and the ATMP regulation, again, are in the process of being revised. We do believe, as EBMT, as GoCART Coalition, and I believe as EHA, we do believe that it should be maintained in the next version. But that's ongoing discussions. And so again, to come back to your original point, what we have realized over time is that academia needs to have its voice listened to by policymakers, especially at the European levels. And we need to get organized to have people who can go to the European Commission on a regular basis, who can answer surveys, who can answer public consultations.
Finally, there is also data harmonization. There has been a registry created by EBMT and is collecting data from all patients that receive CAR T. How was this registry set up? What kind of data is it collecting?
Yeah, data actually may be the most important aspect, because we need data to run proper analysis and support relevant decisions for all the aspects that we previously discussed. The EBMT registry has collected over time information on more than 700,000 patients who underwent hematopoietic cell transplant, and more than 800,000 transplant, because some patients do receive multiple transplants. Based on this experience, in the mid-2010, we expanded the capacity of the EBMT registry to capture data not only on transplant patients, but now on patients treated with CAR T-cells. EMA published a positive opinion on the cellular therapy module to register patients treated with CAR T-cells and collect data on follow-up. We now have more than 12,000 patients registered with the EBMT registry, and we have more or less limited follow-up on these patients, and it's growing. On top of that, we have contracted with some of the main CAR T-cells manufacturers to run what we call PAS, Post-Authorization Safety Survey. And these are intended to capture information with highest granularity in order to be able to detect signals for unpredicted or unpredictable toxicities or side effects in real world conditions. And we've been publishing the first results of large cohorts of patients included in these PAS studies. But then during this six-year process, we realized that, again, there were many interested parties in the field, and that each of these interested parties had different interests. So we need to move on and enrich the CAR T-cells registry by adding information or maybe refining already included information. Recently, we've used a methodology which is called Delphi survey. And so we ask people what kind of information is important to them and in which format, basically. And we had a meeting with another European initiative that is called T2Evolve. And what was somewhat surprising was that actually there is only a minority of information for which there is a consensus. So maybe also that suggests that we may not be aiming at collecting a huge amount of information, but possibly only a limited number of information, but of high quality. Or maybe we could collect information with a very high definition, if I can say, only on samples of patients. Ironically, I commented that we closed the loop and came back because that has been the design of the EBMT registry for many years now, but at least we have a scientific approach there to build a consensus. So we try to promote use and reuse. We believe that analyzing data sets also results in improving the quality of the data because you obviously double check and you identify inconsistencies or errors. So we really try to promote, and this is the goal of the scientific excellence work package, where we have launched a call of interest for the last 4 years and selected now 11 projects, 3 this year in 2024. So one key objective of GoCART is really, to open the door to new users. This is a complex landscape because the EBMT registry basically used to be the only registry for hematopoietic cell transplantation in Europe. And the situation for CAR T-cells is very different because that has generated interest from many more communities. So how do we try not to duplicate again efforts and money and energy? And this is something we are working at GoCART.
So to be naive, if you're an investigator and you want to access this data, to work with this data, how do you do it?
Well, it's quite simple because there is a door to enter the EBMT registry and you can contact people there. And also there will be another call in 2025 for GoCART. There are 2 coordinators for the GoCART Coalition who are ready to answer any sort of questions in relation to GoCART activities.
So there is no need to have funding from GoCART to access this data. So you can have your own funding?
Yeah, you can have your own funding. And again, you are quite open and flexible in terms of giving access. In the process of scientific excellence, there is a reviewing process in place, of course. But otherwise, we are very happy that people outside of EBMT can use the data in the registry and bring new ideas and new initiatives.
Do you have any example of a project that has been possible because of this EBMT registry?
There are 11 projects that are carried under the auspice of the GoCART Coalition. One of the 3 that we selected was the use of CAR T-cells in patients who have also received solid organ transplants. We've looked at the influence of lymphodepletion as an example on the outcome of CAR T-cells. But we still have a number of questions. We are digging always deeper to further understand what are the determinants of success when treating patients with CAR T-cells, and also adjusting the use of CAR T-cells to an ever-changing world. The therapeutic landscape in the diseases that we treat with CAR T-cells, let's say lymphoma, myeloma, is ever expanding with always more options We've seen that with the introductions of what we call B-specific antibodies. So one of the questions no one has the answer. Which order should we use those products? Should we use them sequentially, simultaneously? Should we use one to bridge to the other? So many of these questions will be addressed through the use of registries. And again, we'll need the contribution of more individuals coming from different organizations.
So how do you see the future of GoCART?
One of the big projects is to have this passport ready to use. At the same time, we will keep promoting the use and reuse of the data in order to better understand what is at stake when treating patients with CAR T-cells and other forms of immune cell therapies. And also, we need to address the consequences of these therapies moving outside of hematology to different fields. There is a lot of excitement on using CAR T-cells for autoimmune diseases, as an example. Lot of hope and excitement in the field that needs to be confirmed in real-world conditions. And yes, these patients will need to be registered. We believe the BMT registry may be a suitable tool to register these patients. EBMT has created an autoimmune disease working party for many years because before CAR T-cells, we were using, as an example, autologous hematopoietic cell transplantation to treat some patients affected with autoimmune diseases or chronic inflammatory disorder. Most of the expertise is outside of EHA and outside of EBMT. So we'll work on bridging between these different communities.
So the limits of the work for this coalition, especially for the registry, are ever expanding. The work is not done.
No, the work is not done because we are living in a changing environment. So even if we were happy to claim today that we have met 100% of our original objectives, which obviously is not true, there would be new objectives because, again, the field is expanding. It's very hard to predict where the actual and impacting changes will take place. We also expect future progress in the field of solid tumors, where there are many unmet needs. You may have heard of the original and encouraging success in the field of glioblastoma, for example, or in children, neuroblastoma, medulloblastoma, and so on, trying to anticipate what would be the consequences, let's say, if a CAR T-cells could be used to treat patients with frequent forms of solid tumors, let's say colon cancer, for example, or lung cancer. And again, GoCART will be there to contribute to these advances.
Is there anything else you would like to say to the audience? What would be your takeaway message?
Well, my takeaway message is, again, GoCART is a community and you're welcome to join the community. A biomarker, if I can say so, of our success would be to have more organizations and more individuals affiliated with GoCART. And from a more personal viewpoint, I was one of the individuals who originally thought that was something useful to the community. And I would be delighted to have junior people join the community and join the initiative.
Well, thank you very much, Professor Chabannon, for this insightful conversation and for sharing all your experience with us. Thank you to all of you for listening, and stay tuned for our next episode.